A lot of people believe that if you don't smoke, you don't get lung cancer.
Yes, that's right.
There's almost a complete wrong concept. A good surgeon made a complex surgery simple, whereas a not so good surgeon, it makes a simple surgery complicated. When you treat one patient, remember you're treating the whole family. So now, coming to FV hospitals,
Yeah.
right, by this collaboration, we can easily bring down the fees, maybe to about 40% of that of Singapore.
Ung thư phổi là loại ung thư phổ biến ở cả hai giới và gây tử vong hàng đầu tại Việt Nam. Theo số liệu thống kê của Global Can 2020, Việt Nam ghi nhận có hơn 26.000 ca mắc mới do ung thư phổi và 23.000 ca tử vong do bệnh ung thư phổi gây ra. Đáng lo ngại đó là phần lớn các ca bệnh ung thư phổi thường được chẩn đoán ở giai đoạn khá là muộn khi mà việc điều trị đã trở nên khó khăn. Chính vì vậy, việc tầm soát phát hiện ung thư phổi sớm sẽ giúp cải thiện kết quả điều trị cũng như là tăng tỷ lệ sống sót cho bệnh nhân ung thư phổi. Xin chào quý vị đã quay trở lại với podcast Giải mã y khoa, series podcast giải mã những vấn đề y học đang được quan tâm và công việc của những người trong ngành y tế. Tôi là Nam Phương và khách mời trong buổi podcast ngày hôm nay đó là bác sĩ Su Chung Win, chuyên gia phẫu thuật lồng ngực tại Bệnh viện FV, sẽ giải đáp thắc mắc cho quý vị khán giả cũng như Nam Phương về những vấn đề liên quan tới việc tầm soát, phát hiện và điều trị bệnh ung thư phổi. Xin chào bác sĩ Su Chung Win, xin cảm ơn bác sĩ đã đồng hành cùng các quý vị khán giả trong tập podcast lần này. Hello, Dr. Su Chung Win. Thank you very much for joining our audience on today's podcast.
Hi, everybody. My name is Su Chung Win. I'm a cardiothoracic surgeon. I'm a heart lung surgeon. I actually am working at Singapore hospitals. Usually, I'm based at Gleneagles Hospitals in Singapore. I actually graduated from Melbourne, right, from the University of Melbourne in late 1990s. After that, I went to Singapore for training, and I entered the Department of Cardiothoracic Surgery, which is the heart lung surgery. And in 2006, I went to Cleveland Clinic, which is ranked number one, the top cardiothoracic center in the America for almost 30 years by now. And I was the chief fellows in the lung surgery for about 2 years before I came back to Singapore again. And I became consultant in cardiothoracic surgery at the age of 33 years old then. So after that, I practiced at National Heart Centre Singapore for about 4 years before I came to the private. And since then, I've been working at mostly Parkway hospitals, in addition to the other private hospitals in Singapore. Yeah, and by now, you know, after being in cardiothoracic surgery since 2002, so almost 22 years, I've done more than 7,000 lung surgeries. Yeah, and with some luck, you know, so far for all the elective surgery-wise, I hold the record of having no death. Yeah.
Oh, yeah, I'm really impressed by your profile, and I believe that you're
thank
gonna
you.
provide a lot of useful information for the audience in our podcast today.
Thank you.
Yeah, and first of all, as I know that many people are often advised that smoking is one of the leading causes of lung cancer. However, in recent years, the incidence of lung cancer among non-smokers has been increasing dramatically. So what could be the causes of this trend? And is it possible for us to proactively address this issue?
Yeah. Now, so there's been probably a misconcept that, you know, in 1980s and even 90s, when I was a medical student, a lot of people believe that if you don't smoke, you don't get lung cancer.
Yes, that's right.
There's almost a complete wrong concept. So now, you know, we have, you know, for the past 20, 30 years, we started to see a lot of patients, actually, they never smoked in the whole life. In fact, if you come to my clinics, most of the patients, they don't smoke and they get lung cancer. So the danger part for lung cancer is that there is no real risk factors. Okay, I mean, there are some, you know, factors like smoking. Smoking does increase the chances to get lung cancer, but that's
Yeah.
not the only one. And having the family history of lung cancer also increased there as well. But unfortunately, the majority of the lung cancer patients, they never smoke. Okay, and we identify one group of patients that is actually at high risk for cancer, that is Asian, female, in their 50 plus years old and never smoke. Okay, so as to why this group, we don't know, but by statistics, it shows that this group of patients, they run the highest risk of having lung cancer. And the other thing is that lung cancer, although is, in terms of incidence, is number second or number third, right, whether you're female or males, but it's the number one killers among all the cancer. Right? For example, for the second commonest cancer that kill the population is colon cancer. In the world population, about 700,000 populations die from colon cancer a year.
Yeah.
But lung cancer in the world, 1 year, almost 2 million people die from lung cancers per year.
Wow.
Right? And most of these, about 70 to 80%,
Yeah.
are actually Asian. So lung cancer is an Asian disease. Okay? Unlike many other cancers.
So it means that when we compare to another regions, so Asian would lead.
Yeah.
The top.
So once an Asian, especially
Yeah.
like Chinese, Vietnamese, Singaporean, we are already at risk. Right? This is a geographical kind of things. It may be running
Wow,
something in the
interesting.
genetics, but being Caucasian, your risk is lower than this Asian.
Oh.
Yeah. So if you say, is there a model to try to identify who are the patients at risk? Unfortunately, there's no model. So the only way to prevent lung cancer, or to detect early lung cancer, is by screening.
Oh, yeah.
Yeah. And very unfortunately, a lot of people know that there is a breast cancer awareness there, there's
Yes,
a
that's
colon
right.
cancer awareness there, but a lot of people don't know there's a lung cancer awareness there. And that's the weird things about it. Remember during COVID time, if you remember correctly, when there is a 2 million population died from COVID, the
Yeah.
whole world financial crash. But every year, there's 2 million population in the world died from lung cancer. But people do not recognize that,
Yeah.
right? So there is a severe under-recognition of lung cancer, which leads to severe under-screening for lung cancer.
Doctor, lung cancer has a mortality rate, and that is a disease which is very difficult to treat. As I know that it is often detected at advanced stages or when symptoms become severe, and normally the initial signs of lung cancer can be easily mistaken for common illnesses.
Yep.
I mean, for the symptoms of common illnesses, and are not quite clear. So, are there any ways for us to distinguish these signs and enable high-risk individuals to screen and detect lung cancer earlier?
Now, you're right that lung cancer can be very difficult to treat. That's because most of the time, lung cancer are detected very late stage. Say in 1990s, right? Most lung cancer are detected, maybe 90% are detected when they are in the terminal phase. That means the last phase. So, over the years, despite all the encouragement in all the screening, despite all the awareness that we created, in recognizing the lung cancer, still most of the lung cancer nowadays, I would say up to 70-80%, when they are detected, they're already in the advanced stage. And the problem is that lung cancer is not like breast cancer. It's not like colon cancer. Breast cancer, you can feel the lump. Colon cancer, you bleed in your stools. So you got some signs. But lung cancer, there is no signs at all. Okay, imagine I can take out 25% of your lungs. I can take out half your left lungs or half the right lungs. And the patient can function almost normally. They are not breathless. They're not coughing. No, so how can a 1 centimeters, 2 centimeters, or 3 centimeters, a lung tumor give you any symptoms? Okay, in the drama series, they always put down there, coughing up blood, all these things. That is not lung cancer. Most lung cancer are no symptoms, right? That's why it's called silent killers. All right. By the time you detect the symptoms, for example, breathlessness, for example, severe coughing, bone pain, headache, that is because this cancer has already advanced to stage 4. They start to spread to the chest wall, they start to spread to the brain, they spread, to the bones, to the backbone, whatsoever. So that's when they cause symptoms. So the scary part for lung cancer is that there's no symptoms.
Mm.
Okay, most of the time, people are diagnosed with early lung cancer purely because they are lucky, or they go for screening.
Yeah.
Nowadays, CT scan forms a very popular modality, right, to scan the rest of the body, including the lungs.
Yes.
People go for heart scans, they go for liver scans, they go for neck scans, and lungs being quite central to the body. Often part of the lungs will be included in the scans.
Yeah.
That's how a lot of the times, by pure coincidence and luck, they found that, hey, there's a tumor in the lungs. Then we proceed to do a complete scans. That's how they found out about the lung cancer. If you say, hey, he's coughing blood, whatever, that's why he got found out about lung cancer, that is the rare cases. Okay? So that's why lung cancer is difficult to treat. But if you detect early, right, then lung cancer is actually very easy to treat. And the cure rate is actually very high. If you screen somebody for cancer and there's nothing you can do, there's no surgery, there's no chemotherapy, then don't detect, don't screen. But if you screen a cancer, for example, lung cancer, and there is an early phase you can detect the cancer, and there's something you can do easily to treat the early phase and make a big difference to the survival, then it's worth screening. Right? This is why lung cancer screening is that important.
Yeah.
For example, stage 1A lung cancer, we talk about 5 years survival. Right? 5 years survival, almost by layman terms, if you pass the 5 years, you're almost be considered cure. The chances for 5 years survival, that means cure, for stage 1 lung cancer, average is about 90%, 92 to 95%, depending on whether you're early stage 1A or later stage 1A.
Wow. Yeah.
But the moment you become stage 1B, you can imagine the rate drop significantly to about 78 to 80%. That is about 15% drop, just 1A to 1B. The moment you hit stage 2, right, there's 2A and 2B, but in general, the survival chances in 5 years drop to 50%. And stage 3, it dropped to about 20 to 30%. Stage 4, there's no cure. And there's one more stage that a lot of people don't understand. It's stage 0. Stage 0 means it's pre-invasive. That means they have not developed into a real invasive cancer. That is the one that a lot of doctors or people or patients, they're neglected. Okay, pre-invasive means that they have to be very small. So the smaller the tumors, you remove it, the higher the chance, because it might be in stage 1A or even stage 0.
Yes.
But to fulfill stage 0, one of the criteria is that the invasive component cannot be more than 5 millimeters. 5 millimeters is very small. And how can that be seen on the X-rays? Cannot. How can that produce any symptoms? Cannot. So the only way is to do this by CT scan. Right? And if you detect stage 0 lung cancer, which is the pre-invasive lung cancer stage, what does it mean? It means that all you need is a simple surgery. 20 minutes to 30 minutes, small little 1.5 centimeter cut on the skin. Fortunately, surgical technique-wise has changed so much.
Yes.
So now, no longer than the last time, 20 years ago, you need a big cut, painful, cut a lot of muscles. Recovery is slow. Hospital stay is long.
Yeah.
Post-operation, cannot go back to work for a month, for 6 weeks. Now, we just need small cut, 20, 30 minutes, lose a little bit of lungs, minimal pain after 2 or 3 days, almost no pain medicine, go back to work after 1 to 2 weeks.
Yeah.
And if it's cancer, you stand a good chance, almost 100% to be cured. And secondly, right, more important thing is that your cost also is a lot lower.
Yes.
And one thing that a lot of people forgotten is the stress. I share with you one of the patients, his story with me.
Yeah.
This is a very successful businessman. He's a politician.
Yes.
He worked in my clinics. As he walked towards me, he said, Dr. Su, take out this lung tumor for me. I said, I have not even seen the scans. I have not even talked to you. He said, yes, I know. But I have these things for a year.
Yeah.
I am a successful businessman. I'm a good golfer. He said, every time when I go and play golf, when I win the games, I'm supposed to be very happy. But unfortunately, the moment I'm at my happiest moment, I thought, hey, I got a tumor, a mass, a white spot in my lungs. Is this a cancer or not? He said, when I clinch a deal in the business, I'm supposed to be very happy. But during the celebration dinner, suddenly it struck me, do I have a cancer? When cancer becomes stage 1 to stage 2 or 3, it cannot reverse anymore. So what's happening to my mass in the lungs? Is it getting bigger? I don't know. So finally, he went to a holiday with the family, and they were taking the family pictures together. And he said, that struck me. Is this my last holiday with my family? He used the word, this is medical imprisonment. He said, I am in the prison. My life cannot carry on like this. So for whatever it is, I want this to be out. So if this is a cancer, you earn the operation. Right? You're cured. You're high chance to be cured of lung cancer.
Yes.
But if this is not cancer, the least of it is that your stress is gone completely and the life can go back to normal. But despite saying so, I'm not saying that every lung tumor must be removed. I never say that. Okay? You need an experienced eyes, the surgeon or the pulmonologist, the lung physician, or the oncologist who deal with all these kind of tumors. They must be able to read that with good experience and decide whether this tumor or nodules, they call it, or white spot, whether is it worth to be removed. I cannot be removing everyone because a lot of them are benign. For example, if this guy has tuberculosis before and this is calcified or got calcium inside there, we shouldn't be removing this at all. Right? Some of them, after you've seen enough of these scans, one look, hey, this is an infection. This is a scar. This is a lymph nodes. Don't take it out. Okay? So you need not only a surgeon who is experienced, who has got good skills, but you need to be ethical and professional. You cannot remove it just because you want to remove for the personal gain. Right? Because a lot of surgeons have done that.
After hearing your insights, I've come to realize the importance of early lung cancer screening, and early detections would result in better treatment outcomes for lung cancer patients. By the way, I'm curious about how lung cancer treatment has evolved from a technical perspective. What new techniques are being applied today, and what is the role of technology in lung cancer treatment?
Yes. Okay. So, good questions. I am actually fortunate because of my age. So, I was involved and I've seen the evolution of the technical aspects of lung cancer. When I was a surgical trainee, 20 over years ago, we were in the era when all the lung surgery, whether it's cancer or not cancer, was done by this thing called thoracotomy. That means a big cut on the chest. The cut is about 15 to 20 centimeters or even longer. Okay, you cut the skin, you cut the muscles, and you spread the ribs. And sometimes you broke the ribs. So obviously, it's very morbid. Right? It's painful, it's bad scarring, and post-operation, it's very debilitating. You cannot carry heavy things and things like that. Now, so over the past 20 over years, the surgical techniques for lung cancer or lung surgery has evolved a lot. From a big cut, gradually the cut, the scar, incision becomes smaller and smaller and smaller and smaller. Comes early 2000s, it comes this video-assisted thoracoscopic surgery, VATS. Okay, so it became very popular, and it was 3-holes surgery. One hole is about 3 to 4 centimeters cut, or we call it incision, and the other 2 smaller one about 1 centimeters. This is what I call minimally invasive surgery, or some people use the word keyhole surgery. All right. So the main difference is that we don't cut the ribs anymore. You don't split the ribs open anymore. It's just a skin cut and a little bit of muscles cut. So the benefit is that the pain is a lot better. The scar is a lot better. The disability is a lot better. all right? And the visualization of the chest cavity by the scope is much better. So rapidly, VATS replaced thoracotomy. Although there's some learning curve, but the whole world was gearing towards that.
Yeah.
Right? And after that, in late 2000s, came this thing called robotic surgery. Robotic surgeries, I'm sure you heard by now, is a surgeon sitting a couple of feet away from the patients, and the robotic arms controlled by the surgeons, and they operate on the patients with so-called higher precision, almost like simulating a small hand instead of chest. I was one of the early surgeons who used robotics to do lung cancer surgeries in Singapore in 2010. After performing a couple of these robotic surgeries, I realized that it's not as good, it's not as attractive as it should be, because it needs also 3 to 4 holes. The operation timing is longer. Post-operation somehow is more painful because the robotic arms cannot sense how much pressure to apply on the ribs. And when things happen, which means if there's an artery or blood vessels injury, it becomes a panicky situation. The surgeons go to scrub out, and then go to quickly come and open the chest. And that few minutes is important, it's crucial. You might lose a lot of blood and put the patient at risk. And the cost is also a lot higher. So at the end, I decided to give up the so-called 3 to 4 holes robotic surgeries and continue the 3 holes VATS surgery. And since then, technical part continue to evolve. So since early 2010s, 2013 or 14 onwards, 3 holes become 2 holes. We get rid of 1 additional small holes. The lesser the holes, the fewer the holes, obviously there's less injury to the chest. So that translates to less pain. Right? And since the last 6 years, since 2018, we converted to 1 hole. Okay, so just a 1.5 to 3 centimeters hole, we can finish most kind of thoracic surgery. Whether it's a simple a hole in the lungs, whether it's lung cancer surgery, whether it's esophagus surgery, whether it's infection in the chest. Right? So, in the way, comparing this single hole, we call it uniport VATS surgery, versus a robotic surgeries, truly speaking, I didn't see much benefit in using the robots. Except that robotic surgery is a marketing tool. It made people who don't understand all these surgical techniques that think, using a high-end technologies means it's better. I don't think that's true anymore. Single port VATS, we use very simple, very basic kind of thoracic surgical instruments, and we achieve the same aims as all the so-called robotics. It's shorter operation timing. For lung cancer surgery, to remove half the lungs, we just take about 1 hour to 1.5 hours. Whereas the robotic would definitely be longer than that. We are only 1 hole, so aesthetically, cosmetic-wise, we are better than 3 holes or 4 holes. We are a lot safer. Anything happen, we are there. We just open the chest and control the bleeding. Whereas the robotic guy, they have to scrub out and change up and then come and open the chest. We are a lot safer. We're a lot cheaper compared to the robotic surgeries. Especially Singapore, high cost country, robotics is a lot more expensive. Right? And post-operation, almost very few of them will require what we call morphine or narcotics. That means injection kind of morphine, all those kind of medicine. They just need oral tablets, right? 2 or 3, usually 2 oral tablets, pain medicine, and after about 2 or 3 days, maybe down to 1 paracetamol, 1 single tablet, and then after 3 to 4 days, no need medicine anymore. Right? So because of these changes in the techniques, so it also made people more receptive to go for lung resection, to go for lung surgeries. If you tell the patient, you got a 6 millimeters tumor, I got to make a big cut for you, or 3 holes, whatever for you, I think they'll be quite reluctant to go for it. It's painful. But if you tell them that, hey, I just need maybe 1.5, 2 centimeter cuts for you to achieve what I want to achieve, I think a lot of them will be able to accept that. So there's what has been the changes in the surgical technical evolutions in lung surgeries as a whole, not just lung cancer.
However, to operate such advanced treatment techniques like what you mentioned, I believe that the skills of the medical team have to meet the specific standards. So could you share a little bit about the human resource requirements in addition to technical demands?
Of course, to do a surgery is very surgeon-based, all right?
Yeah.
After it being in surgery training, been doing surgery for almost 20 over years, I come to realize one thing. In a good surgeon, all right, probably 70% is inbuilt. That means he's born with the kind of ability. 30%, this is my own perception, yeah? 30% is due to training. You can put two surgeons through the same training program, but it come out as completely two different standard surgeons because there's something called inbuilt, right? So I think what happened is that for VATS surgery, there is a learning curve, but it's not so steep. After you've done about 50 cases or so, you'll be quite comfortable to do it. But that also depends on whether this guy has the talent to do it. If he doesn't have this ability, inbuilt ability, he might have done hundreds, 200 cases, and he still keep getting into trouble.
Yeah.
But if this guy is gifted surgeon, after about maybe 20, 30 cases, he's already used to this kind of surgical techniques. So it's not something that is too difficult. The learning curve is there, but it's not that steep.
Yeah.
Yeah. And the team-wise, most of my cases are done between me and one nurse. Sometimes the more complex one, we get another assistant, so a doctor's assistant to come in and help, who understand the anatomy, right? And it's quite safe. We hardly convert from a VATS to a so-called open. That means we hardly encounter any major complications. So thoracic surgery, we have already make it, not as complicated as it sounded to be in the past. All right, I always tell my fellow colleagues, a good surgeon made a complex surgery simple, whereas a not so good surgeon, it makes a simple surgery complicated. So ultimately, this surgeon has to be gifted, number one. They have to undergo a proper training.
With over 2 decades of experience, could you share with us some memorable cases of your lung cancer patients so that we can understand more about the advancement as well as the progress in medical treatments for lung cancer?
Okay, yeah. Over the past so many years, I have performed more than 7,000 surgeries. I must say that every case is memorable. All right, every case we take effort. We're putting our best to treat the patients. And I always tell people, when you treat one patient, remember, it's your privilege that this patient lived a life to you. It's a privilege that family let you operate on their loved one. So we really give him the best in the sense that not only during the operation, not only during the surgeries, but after the surgeries, we look after them. Which is one of the reasons why I became a private surgeon, because I don't trust anyone else to look after the patients. In the private hospitals, we look after the patient ourselves. For every small things all the way up. So there are many stories, that, every now and then we will recall, and it will give us the so-called encouragement to continue what we're doing. It's very tiring, but it gives us the energy the drive to continue on. So just share with you maybe 2 cases. Nowadays, one thing is that lung cancer is getting younger and younger. The trend is that the lung cancer the lung cancer sufferers, the patients, they seems to be getting younger. I don't know why. No one knows why. Maybe 10 years, 20 years later, we know the answer, but not now. I got one patient. She's only 32 years old. She was found by pure coincidence that she got a small lump in the left upper lungs, about 1.5 centimeters. Okay, on the PET scan, which is a so-called cancer screening scans, it light up. So there's a chance that it's cancer, but also there's a chance that it may be infection. And she's only 32. The younger you are, the less likely these are cancer. Okay, but the treating doctors, the lung physician, asked me to have a look. The tumor is very central next to the blood vessels. So there's no way that we can do a biopsy. That means put a needle inside and get some cells. There's no way to do that. So our option was to observe to see whether the tumor grow bigger or take out the whole upper lobe, which is half the left lungs, which to most people is very morbid. It's far-fetching to remove just the upper lobe, half the lungs for nothing, I mean, may not be anything. So I talked to her, obliged to offer her these two options, but I was inclined to tell her that, hey, let's just observe this one for a while. All right? So I left the room. I remember that. I left the rooms. After about 2 hours, she called back. She said, Doctor, I want to see you again. So I went there again. She said, Doc, take it out for me. I said, do you know what you are going for? She said, yes, remove half my left lungs. I said, you know that it may not be cancer. He said, yes. Then I said, it's going to be a wasted surgery. You lose your lungs for nothing. He said, I understand. He said, but Doc, he said, I am only 32. I'm fit and young. I can afford to lose my left upper lobe. He said, I know you're good surgeons. Unlikely you're going to kill me, but I can afford to lose this 25%. I can get it back slowly. But he said, Doctor, I got one pair of twins. They are 1 year old. I cannot afford to make a mistake. It's lung cancer. I'm going to die in 2 or 3 years, and I can't see my twins grow up. I can't have my twins not having a mother. Alone, their growth. So I said, Doctor, please take it out for me. I consented to this. So I said, okay, it's a decision. I took it out for her by VATS. The answer is stage 2A lung cancer.
Wow.
Okay, so never said young patient doesn't get a cancer. So stage 2A lung cancer, she went for chemotherapy. This happened about maybe 6-7 years ago. Until now, she's all well. She's cured. Okay, so this is a success story. On the other hand, I also have a patient. This is a fellow doctor's colleague's wife. When she saw me, she was about 36. Beautiful lady, beautiful family, 2 young kids, loving husband who is a doctor. Okay, she came to see me because she was coughing. She got symptoms. And when we did a scan, she got a lot of small lung masses, nodules in the lungs. We thought this is probably infection. She's only 36, never smoked, no family history, no risk factors. Okay, she's healthy, she run marathon. But we say, hey, let's just be sure what this is, what's going on. So I said, let's go for the surgery to remove a little bit of lungs to see what this is. Okay, I still remember the anesthesiologist, the doctors who put her to sleep, is the husband's good friend. So before surgery, no one thought otherwise. We thought it's going to be benign, it's going to be infection. So she still was joking, doctor, later on, when I go to sleep, do some plastic surgery on my face, whatever, just kidding, Everyone was joking because we didn't expect anything. So when I did a simple lung biopsy, we sent it for immediate testing. The pathologist, who didn't know who this patient is, 5 minutes later, she walked in the theater rooms. She said, oh, it's cancer. Wow, means this is stage 4 lung cancer. I still remember so clearly the anesthesiologist, the friends to this couple, she straight away broke down and cried. Okay, she couldn't accept that their good friend has got stage 4 lung cancer at this young age. I came out, I told the husband. The husband was blank. He almost collapsed. He said, unbelievable. He said, I can't think anymore. I leave it to you guys to decide what to do for my wife. Since that day, she stayed in the hospital for about 2 to 3 days. I remember every time when I go into the rooms, the husband was hugging the wife. Okay, it's painful to see all these things. The children were there. You know, the whole family becomes so sad.
Yeah.
After that, the husband took 1 year off the work. The children stopped schooling for 1 year. They went to a tour around the world, whatever. And what I heard is that every night when the family go to sleep, she stay awake. She do the video recording. Okay, she recorded her wishes for the 2 children, for the husband, during their birthday, during the New Year, during the Christmas, whatever. Now she has to do all these things to keep the family, the children grow up with a mother. This is very miserable. And I still remember the last video was when the children got married, the husband will play for them. Mommy's wishes to your wedding. That's the last one. So after 1.5 years later, she passed away. Okay? So you think about these 2 cases.
Yes.
Right? One detected early, relatively early, not early, it's stage 2A, but she's cured. The twins grow up with a mother. The family is a healthy, complete family. The other one, the 2 poor children grew up without a mother. The family is no longer complete. Right? So it's a huge difference.
Yes.
That's why I say, when you treat one patient, remember, you're treating the whole family.
Yeah.
For us, we deal with heart and lungs, we deal with all the complicated cases.
Yeah.
There are cases that come in, emergency, and we couldn't save.
Yeah.
When we couldn't save a patient, you see the whole family devastated.
Yeah.
So when you didn't manage to save that particular patient, you actually failed the whole family.
Yeah.
Which is why I put in so much effort in every single patient. And that's why I got such a good results for now.
Yeah. So how do you view the demand for screening and treating among Vietnamese patients? Given that there are over 25,000 new cases of lung cancer every year.
Yeah. So you must understand that this 25,000 new lung cancer is the recorded lung cancers.
Yeah.
What about those unrecorded? It's more than 25,000. It's probably a lot more.
More than that, yes.
All right. So the question is how to screen them. You cannot screen everyone. You cannot screen at 20 years old. So there are guidelines, that, hey, screen at 50 years old, when there is a family history, when there is smokers, all these things.
Yeah.
But we're seeing, as I said, we're seeing the increasing younger trend for the lung cancer.
Yeah.
And these are the ones that actually got a lot more to lose. If you get lung cancer at 30 years old, 35 years old, and if you don't save this patient, average lifespan is 85 years old, you lose 50 years. If you're 60 years old, you lose 25 years. So what's the real answer? I don't think anyone knows the real answer.
Yeah.
But I know that, in many countries now, okay, they are going against the so-called recommendation.
Yeah.
At 30 plus, they start to do the low-dose CT lung screening. Fortunately, CT scan now for the lung screening is low radiation. Very low radiation, and they're cheap.
Oh,
okay?
Yeah.
So as one of the criteria for screening is that it must not be invasive. That means it cannot have injection here and there. It must be minimal side effect. It must not be expensive. There must be something that can be done when you pick up early.
Yeah, because you already mentioned about the lower cost when we use lower radiation. So by the way, could you be more specific to share with us about the cost for cancer treatment, lung cancer treatment in Vietnam and also compared to Singapore?
Okay. Now, Singapore, obviously, is getting more and more expensive.
Yeah.
Which is why we are here today to form this collaboration with FV hospitals.
Yeah.
Because Singapore healthcare cost is known to be high, and it's getting higher due to inflation.
Yeah.
Right? It's beyond any of our control. It's not due to one person's, fault or effort. It's just how it is.
Yes.
So in Vietnam, obviously, the total cost is a lot cheaper, right? Which is why we are now forming this collaboration to utilize the much cheaper hospital facility fees in Vietnam to benefit all these patients. As you know, the total hospital costs include the hospital and the surgeon cost. Right? So if they come to Singapore, for example, a lung cancer surgery, it can easily cost about 80,000 Singapore dollars.
Wow.
How many people can afford that?
Yes, that's right.
In Singapore, because 60-70% they're covered by insurance. But Vietnamese, if you come to Singapore without international insurance, which most Vietnamese don't have,
it costs a fortune.
you have to cost a fortune.
That's right.
I got a patient who came to me to do a lung surgery to remove the whole left lungs, I remember. Right? She said the doctors in Vietnam told her 50% risk of death. When she asked me, I said 5%. And she trusted me. She said, give me some time. She went back to Vietnam. What did she do? She sold her house. She sold the house and come to Singapore for the treatment. It's very expensive. So now, coming to FV hospitals, right, by this collaboration, we can easily bring down the fees, maybe to about 40% of that of Singapore. It's going to be still expensive, but it's much cheaper than Singapore. So it makes it a lot more affordable for the Vietnamese communities. Vietnam got about 100 million populations. Maybe only 5 million, 5% or less, they can afford to pay by cash to come to Singapore for expensive treatment. But if you can bring down the fees by half or 60-70%, I think a lot more Vietnamese community patients can afford that by now.
That's right.
And don't forget, you don't look at just the hospital bill itself. When you come to Singapore, you are not only just paying the hospital bill. You also pay air ticket. You also pay hotel, taxi,
that's right,
food,
many
everything
additional
else.
fees. That's right.
Everything else. So if, let's say, there are two patients, one stay in, for example, FV hospitals, one stay come to Singapore, I think the total cost for that period of time in Vietnam maybe it's only about 30% or less compared to Singapore. So that really make it a lot more affordable. And in addition to cost, when you're sick, don't just look at money. Right? When you're sick, you want support by the family. Right? If you come to Singapore, because cost is so expensive, usually they come with one family members. But that means you lack your support by friends, by your other family. There's a lot of anxiety that people, again, neglected. But if you're in Vietnam, in your own hometown, your whole family is there.
Yes, that's right.
And this kind of social support is not something that money can put down to. Okay? And one more thing about the cost is that when we talk about cost, it's always very sensitive. Now, let's say in FEV hospitals, this is a private hospitals, okay? So because of the facilities, because of the doctors from Singapore and things like that, so it will be foreseeably more expensive than the other private hospitals in Vietnam. Let's say the other hospitals are charged about 15,000 and FEV, let's say they charge 35,000, 40,000 in total. $20,000, $25,000 difference, for example. But as I said just now, surgeons are different from physicians. Physicians give drugs. If I'm an oncologist, you got lung cancer, I give the drugs. This drug is the same as another oncologist will give. It's the same as the oncologist will give. There's no difference. But surgeons, the hands are all different. Okay, physician, give the drugs BMW for the cars. But for surgeon, it can be Toyota, BMW, Ferrari, Lamborghini. Right? And what does that mean? The performance are different.
Yeah, of course.
And performance difference translates to outcome. Right? If you get a not so good surgeon, what does that mean? It means your operation time will be longer. It means your risk will become higher. It means your complication after the surgery will become more. Your hospital stay become longer. Right? And your recurrence of cancer become higher.
So, with the collaborations with FV hospitals and the establishment of the O2 Center, what new techniques will you be bringing to Vietnam, and what are your goals and expectations for
Yeah.
the O2 Center in Vietnam?
So right now, O2 consists of 2 cardiothoracic surgeons
Yeah.
and 11 lung physicians. Right now, it's only me that will come here, every now and then to work together with the thoracic surgeon in FEV hospitals.
Yeah.
They've got 2 thoracic surgeons. So we're going to work together. It's a collaboration,
Mm.
right? So the idea is that at the beginning, of course, it depends on the volumes. I'll come maybe once a month for a couple of days.
Yeah.
We'll do the surgery together, all right? Give the best to the patient. And after surgery, once the patient is well, right, or confirm that they'll be safe, then I will go back. Then the rest of the management will be dealt with by the local surgeons. But of course, every day there will be a teleconsult. As I said before to you, I'm very careful,
Yeah.
right? So we will watch the patient until they're discharged. So there will be a day-to-day teleconsult. Given all this technology nowadays, simple teleconsult by WhatsApp, whatever.
Yeah.
So that's what we are going to do. And surgical-wise, we're going to propose, most cases to be done by VATS. Hopefully,
Yeah.
most will be done by single port, single hole.
Mm.
In my own practices, about 95% of the cases in Singapore are done by single hole.
Thank you so much, Dr. Su Chung-wen, for providing such valuable information to help us understand more about lung cancer relating to high-risk groups, screening methods, and the importance of early treatment. I believe that this knowledge that you shared today already helped us gain a more comprehensive understanding of lung cancer.
Sure. Thank you very much. Thank you for the invitation.
Thưa quý vị, ung thư phổi thường không có những dấu hiệu rõ ràng ở những giai đoạn đầu và người bệnh chỉ được chẩn đoán khi ở những giai đoạn khá muộn, khiến cho việc điều trị ung thư phổi gặp nhiều khó khăn và tỷ lệ tử vong cũng sẽ cao hơn. Chính vì vậy, việc tầm soát ung thư sẽ giúp cải thiện kết quả điều trị cũng như là tăng tỷ lệ sống sót cho bệnh nhân ung thư. Việc tầm soát còn có thể giúp cho theo dõi sự phát triển của các khối u nhỏ, đánh giá kết quả điều trị cũng như là giảm nguy cơ phát triển của những khối u ác tính mới, đem lại cơ hội điều trị hiệu quả hơn, bao gồm phẫu thuật, xạ trị, hóa trị trong những giai đoạn đầu của bệnh ung thư phổi, giúp nâng cao chất lượng cuộc sống cũng như là nâng cao tuổi thọ cho người mắc bệnh. Nam Phương tin rằng sau buổi chia sẻ với bác sĩ Su Chung-wen ngày hôm nay, quý vị khán giả đã có thêm góc nhìn cũng như là hiểu rõ hơn về tầm quan trọng của việc tầm soát, phát hiện và các phương pháp điều trị bệnh ung thư phổi. Xin cảm ơn những chia sẻ của bác sĩ Su Chung-wen và cảm ơn bác sĩ đã đồng hành cùng các khán giả trong tập podcast lần này. Xin chào và hẹn gặp lại trong những tập podcast tiếp theo.